Hi, I'm Addie, and today I will be talking a little bit about inequity intersectionality. So how racial, socioeconomic, and climate inequities exacerbate each other, resulting in increased inequities in health and medical treatment. But first, a little bit about me. My name is Addie, and I'm 16 years old. I live in Chicago, Illinois, and I'm a rising junior at Walter Payton College Prep. I'm on my school's tennis team, and I'm also a member of our Medi Club. I also write articles for my school's science journal. In my free time, I love to cook and bake and take pictures of the food I make for my Instagram food blog. I want to preface my presentation with a little bit of background on how I first had my eyes opened to the myriad of inequities present in global health. Last year, I traveled to Peru with New York Times student journeys to learn about public health and development in the Andes. When talking to some of the people working at Sacred Valley Health, an organization dedicated to improving health in indigenous communities, I learned that indigenous Peruvians are often unable to get the healthcare they need because of discrimination in clinics. Clinics are often located very far from indigenous communities, but even when indigenous Peruvians do seek medical care at clinics, they face blatant discrimination from the typically predominantly white physicians. Even if a white person arrives at the clinic after an indigenous person, the white person will always be treated first, regardless of the severity of their condition. Also, medical professionals and clinic staff usually put no time or effort into learning Quechua, the primary and often only language spoken by indigenous people of Peru. With no way to communicate their symptoms to doctors, indigenous people will generally turn to using only traditional medicinal practices, even in situations where modern medicine is necessary for survival. After returning home from Peru, I started to notice these types of inequities and more all over the US. The most pervasive of the inequities that I noticed were racial inequities, and how they both advertently and inadvertently caused inequities in the medical field. First, I want to talk about one of the most common forms of blatant racism in the healthcare system, racism in medical formulas. The first example of this is the overestimation of EGFR in Black patients. After a study of less than 200 participants in the mid-20th century concluded that Black people have naturally higher estimated glomerular filtration rates, aka EGFR, than white people, a quote-unquote race correction factor was added to the MDRD equation, which calculates EGFR. Scientists have shown that there's little to no evidence backing up this claim, yet many hospitals still use this formula, and as a result, Black patients typically spend much longer on kidney transplant waiting lists compared to their white counterparts with equivalent kidney function. Another example of racism in medical formulas is the commonly used formula for calculating a patient's risk of heart failure. This formula from the American Heart Association asks for an input of race, with the two options being Black or non-Black. This formula adds 3 points to the risk score if a patient is non-Black, which ultimately ends up hurting Black patients because they are much less likely to be admitted into the cardiology ward, even when they desperately need medical care. These are just two examples, but there are so many more that sadly are still commonly used today. But there are also many non-medical related racial inequities across the US that inadvertently lead to healthcare inequities. And one of the major ones is the wealth gap. As of this year, the only race and gender demographic that makes more than $1 for every dollar a white man makes is Asian men. On average, Black, Native American, and Hispanic men and women all earn less than Asian and white men and women. Although this shows that race is the most influential factor in determining salary, it is also important to note that in every race, men earn on average more than women do, which shows that gender disparities also play a role in the perpetuation of health inequities. The graphic on this slide shows the wealth gap between Black and white men over time, from 1950 to 2014. When looking at the graph for Black workers, we see that the gap is slowly closing, but when we factor in unemployed Black men into the equation, it is apparent that little to no change has ensued over the past nearly 70 years. And why does the wealth gap lead to health inequities? Capitalism. We live in a society where money and capital gain are valued above all else, and for this reason, hospitals, healthcare, and the pharmaceutical industry are all for-profit industries. Because of this, the amount of money you have directly correlates to the amount and the quality of healthcare you have access to. The wealth gap means that on average, Black, Hispanic, and Native American people have a more difficult time accessing the medicine and care they need to stay healthy. Another way that non-medical related racial inequities exacerbate health inequities is through the lingering effects of redlining. Redlining is a discriminatory practice by which banks, insurance companies, etc., refuse or limit loans, mortgages, or insurance within specific geographic areas. Redlining was a common practice in cities across our country, including Chicago and Los Angeles, which are pictured on the slide. And even though redlining was banned 50 years ago, its effects are still very present today. Redlining was almost entirely based on race, and cities that practice redlining still see racial distributions across neighborhoods that generally match the ones originally created by the process of redlining. Because of this, the distribution of other factors across cities can affect certain racial groups more than others. One instance of this is the placement of toxic waste facilities in cities across the US. Race is the #1 indicator of the placement of toxic facilities in the US. 60%, or 3 out of every 5 Black and Hispanic Americans, live in communities with uncontrolled toxic waste sites. The reason why this is such a serious issue is that toxic waste facilities emit mercury, arsenic, lead, and many other contaminants which pose serious health risks to those who ingest them, such as asthma, cancer, reproductive harm, and many, many more. To further examine the intersectionality of inequities present in our country, I'm going to dive into how these inequities we have talked about so far also result in climate inequities and climate-related health inequities. One effect of these inequities that is seldom talked about, yet extremely impactful when it comes to health, is the presence of nature within a neighborhood. Trees, parks, and green spaces drive up the property values within a neighborhood, meaning that because of the wealth gap, neighborhoods with a non-white population majority tend to have less trees and green spaces. This perpetuates racial inequities in health because being around trees and nature lowers cortisol levels and activates our parasympathetic nerve system. This means that being around trees lowers overall stress levels, and those who are around little to no nature in their day-to-day lives are far more likely to have worse mental health than those who are. Another way that a lack of nature within a community can affect health is through the urban heat island effect. Trees, grass, and lakes all cool a neighborhood down by providing shade and evaporation, but buildings, pavement, and cars all heat a city up. This means that communities with few to no natural green spaces will be hotter on average and will suffer worsened effects of climate change, such as an increase in heat-aggravated illnesses, worsened respiratory illnesses, as we are seeing now with COVID-19, and many, many more. In conclusion, if you got anything out of this presentation, it should be that inequities are intersectional, and you cannot fully understand one inequity without looking at it through the lens of others. Another important thing to note is that most of these current inequities stem from systemic issues. So it is important not only to provide relief for individual problems, but also to fight for justice at a systemic level. I've seen Gen Z take action on fighting systemic issues many times, especially over the past few months. And I hope we will all continue to keep that energy going into the future so that one day everyone will have equitable access to the medicine and healthcare they need. Thank you so much. If you have any questions, please email me at adeline.daab@gmail.com. And here are my sources. And I just wanted to end this by acknowledging and thanking the Global Health Leaders Conference and the whole team that put this together. It's truly impressive, everything you've done. And I would also like to thank my teachers and mentors that have inspired me and supported me along the way. Thank you.